So thank you very much again for the invitation to this great meeting. And I will show you how we, in clinical practice, use the EAdi monitoring signal. As yesterday, I have no conflict of interest. You have previously seen this slide, but yesterday, Jennifer, I've shown you this case report, and I think it's interesting because it reflects a bit a change in our practice. It was one of the first cases which made me realize that sometimes we just don't want to see what we can see really easily. And when NAVA was implemented in our unit, and I think it's the same in most units where NAVA has been implemented, this has led, in fact, to a change in practice because of this new information that has been made available in clinical practice to the intensivist, and it makes us realize a lot of things. And this baby was a two months old baby which was extubated after a cardiac surgery, and in fact, when she was extubated, she was placed on the high flow nasal cannula, and as always, the respiratory therapist in our unit switched off the ventilator, and that makes me crazy now, but in fact they switched completely off the ventilator, and we just looked clinically at the patient, and she was not doing so bad at the beginning, but progressively she developed a marked respiratory distress. We decided to put her on non-invasive ventilation, so we switched on the ventilator again, and I then realized that I haven't seen that before. It was stored in the ventilator, but it was really easy to have access to this data, and we just did not look at that. I would not say that I would have intubated the patient before or put her on non-invasive ventilation, but it's a new sign that we should look at really easily in our practice. The problem is that we have this is a relatively new technique, and we have no data on the normal activity in our patients, so that was interesting to describe, and I will give you a few clues how to interpret this new data in our practice. One of the main interests, I think, of the diaphragm activity monitoring has been introduced in the previous talk, that it's probably a very good way to evaluate the impact of our support and to try to find the balance that Alexander Moule spoke about just a few minutes ago. But as I mentioned, it's a new technology. We do not know exactly what should be the right level of EDI in our patients, and so we would try to conduct a study to describe the activity that is commonly observed in the PICU. So we included 55 PICU patients in which we conducted a monitoring of the diaphragm activity, not every day, but at 4 different moments in their PICU stay. In the acute phase, which was not really acute, it was not at the time where the patient was completely sedated or paralyzed. It was when the patient was when the physician thought that the patient was contributing to his ventilation. And I have to mention that the neuromuscular patients were not included in this study. It's important. And what we observed was we were able to describe the evolution of inspiratory activity of the diaphragm, and you see that at the time of PICU discharge, we could say that the diaphragm activity is about between 8 and 25. But there's a relatively large variability, inter-individual variability, but it's not the same if the patient has 1 or 40 microvolts. So it gives you an idea of the normal activity of the patient, almost normally breathing, just before leaving the PICU. And you see that in the acute phase, in fact, the EAdi is much less than the one that is observed at PICU discharge. So this is probably logical, because one goal of the mechanical ventilation is to unload the respiratory muscles, but we can wonder if it's not too much decreased. And in fact, one of the most important findings we had in this study was that there was very prolonged silence. Some patients did not breathe at all when the physician considered that they were breathing. And in fact, in the median value was that during 18% of the time, the patient had no detectable EAdi. So we have to realize that this patient probably are increased risk of diaphragm atrophy. We have no idea of that in pediatric, and so we plan to conduct some research in that aspect, probably with Jean-Paul and also. Another interesting finding of this study is that just in the few hours before the extubation, usually we consider that the ventilation is relatively minimal and will reflect the activity of the patient after the extubation, but in fact this is not the case by far. In fact, you see that during the pre-extubation period, the patients are not working, are much less working than the work that they have to develop post-extubation. So the usual winning parameter that we are using, in fact, are probably providing a certain level of overassistance. Importantly, the low level of peak inspiratory activity are observed whatever the level of driving pressure. So it does not always occur when the driving pressure is high. You can see that some patients with level of driving pressure of 7 or 6 have completely blunted EDI. And this is an example of a patient who was weaned in pressure support ventilation with a level of 7 centimeters of pressure. Everybody would consider that it's minimal ventilation, but you see that there's no activity of the diaphragm until the patient is extubated, and then the activity recovers. Importantly, you have to take into account when interpreting EAdi if the patient has a lung injury or not. And the patient with lung injury have higher diaphragm activity, and so it's important to take into account because you cannot target the same level of EDI depending on the lung condition. If you try to obtain a low diaphragm activity in patients with a very severe lung disease, you will never extubate the patient. And this has also been described by Merja-Kallio in his large randomized control study in NAVA versus conventional ventilation. In fact, she described the evolution of activity of the diaphragm in the NAVA arm, and she observed a relatively higher level of EDI than the one that we observed in the acute phase in our ventilation, in our conventionally ventilated patients. One important thing to keep in mind also is that diaphragm activity is not stable and is strongly influenced by the activity of the children, especially in infants. And you can see that depending on the activity, if the patient is asleep, the activity is very different than if the patient is active or agitated. And it's I always wonder how we could manage this patient with a conventional ventilation, which provide always the same ventilation. It's probably not addressing the need of the patient all the time because these needs are changing all the time. Yeah. Is EAdi a good reflection of the work of breathing? In fact, this is a complex question, and we tried to address this question with Sandrine Essouri last year, and she completed a study in our unit where we tried to evaluate the correlation of the inspiratory EAdi with the swing of esophageal pressure. So to see if it's a good indicator of the work of breathing. And in every patient, the correlation between both information is really good, but there's wide variations between the patients, of course. And also, you can see that in mechanically ventilated patients, if they are in PSV or in NAVA, it's not very different. They're on a slant slope, but after extubation, so the patients were studied a bit later after extubation, it seems that the slope may be different. So it's I think EDI is a very good reflect of changes if the condition of the patient does not change too much. But if you take a patient several hours later or in very different conditions after extubation, we may not, the assumption of the change in EAdi may not reflect exactly the same change in esophageal pressure monitoring. So this remains an important complementary measure probably. One very important also thing to consider is if the patient has a neuromuscular disease, and you cannot assume that the EAdi is the same in this patient. And it's important, and this case makes me realize that aspect. In fact, she was a 3 weeks old baby with a congenital Steinert disease, very severe. She was intubated at birth, and she was transferred from the NICU to our PICU for the weaning phase, and we weaned her in Nava. And initially, we aimed to have a target of an EDI about 15, 20, as we used to do. And after at 3 weeks, we thought that she would be ready to be extubated because she has a good EAdi signal. She has a low level of Nava level. And she was in the Sandrine study, so we put a catheter with the esophageal balloon to check the correlation with the esophageal pressure swing. And what we observed was just before extubation, in fact, she has no effort at all observed on the esophageal pressure. So we realized that this patient, in fact, with 20 microvolt of EAdi was, in fact, not developing any effort. And so we weaned her longer, trying to maintain higher EAdi. And after 3 weeks, we observed the recovering of a certain level of activity, and then we extubated her. But we had to target EDI about 30, 40 to try to make her more active. So it's important when you set a target that you take into consideration the lung disease and the muscular disease. And we observed a similar pattern of high EAdi in other cases of Steinert disease. Another interesting case that we observed recently, which illustrates the importance to look at this signal, which is easy to get in clinical practice, was in an 8-year-old tetraplegic patient. She became tetraplegic in front of us because of a severe arteriovenous malformation in the cervical spine, and in which she developed some complications. And she was completely tetraplegic. She had a very severe MRI with an atrophy of the brainstem, and she was considered not breathing at all. So we were considering diaphragm pacing. And before implementing the diaphragm pacing, we have to conduct a trial of phrenic stimulation to see if the diaphragm remains, the endophrenic nerve activity remains stimulable. And so my colleagues asked me to do a measurement of the esophageal pressure when we do the phrenic stimulation to see if there was a response. And in fact, we were not able to really stimulate with the magnetic phrenic stimulation. We were not really able to stimulate the diaphragm activity, but what I observed was in fact that when everybody was thinking that she was not breathing, we had a certain level of EAdi. And so we disconnected the patient from the ventilator, and in fact she was breathing. And so my colleagues did not believe me because at this point it was not possible for him that this patient was breathing. And so we made some observation of the activity for several hours, and there was an intermittent activity, not really irregular, but we decided to wean her and to put her on Nava, and you see the evolution. 2 weeks later, she has much stronger activity, and now she's being weaned. I don't know if we will be able to wean her completely, but she made a lot of progress, and now she's in Nava with a Nava level at 0.3. I think we will be able. Regarding the extubation readiness test, this has been discussed yesterday, and there are some data in adults, but very few data in pediatrics. This has been a study in 2011 by Gerhard Wolf, and but it's difficult to interpret in my mind because the extubation readiness test was not standardized, And high level of contribution by the ventilator in PSV was introduced, so it's difficult to interpret. I will skip the part on tonic activity because we discussed that yesterday, so I think we could skip that part. And I just think that, just to conclude, say that the EAdi, I think it's a very useful tool to detect overassistance, asynchrony, and to adapt the level of support to the patient condition, but you have to keep in mind the entire patient condition, the lung and the muscle. And it's a good effort, also a reflection of the patient effort to maintain the lung volume regarding the diaphragm tonic activity. Thank you very much.